You're listening to Clinical Conversations. I'm Joe Elia. Our guest is Dr. Csaba Kovesdy, the author of an editorial in JAMA Internal Medicine earlier this month. The editorial concerned a meta-analysis of 18 randomized trials. The analysts reported that more intensive blood pressure lowering in chronic kidney disease was associated with lower all-cause mortality. Dr. Kovesdy's editorial was titled "The Ideal Blood Pressure Target for Patients with Chronic Kidney Disease, Searching for the Sweet Spot." The editorial put the meta-analysis findings into a cautious perspective, which we'll talk about. Dr. Kovesdy is Fred Hatch Professor of Medicine at the University of Tennessee Health Science Center and the Nephrology Section Chief at the VA Medical Center, both in Memphis. Welcome to Clinical Conversations, Dr. Kovesdy.
Thank you, Joe. It's a pleasure to be with you.
I just said that you put the results into a cautious perspective, and I'm assuming, and maybe I'm wrong, that you don't consider the results of that meta-analysis practice changing. Can you talk a little bit about why they may not be, or why I'm wrong?
You're probably right. To the extent that the conclusion or the question for clinicians would be, okay, so what is the ideal blood pressure? What should be our blood pressure target in patients with chronic kidney disease, in whom we're targeting both cardiovascular protection, mortality protection improvement, and also protection from progressive chronic kidney disease. And the current guidelines, the latest guidelines at least, specify usually a systolic blood pressure of around 140, less than 140 as the clinical target. I mean, we could go to JNC8 and divide it by age, which would be less than 150. But in general, people would agree that less than 140 is a good benchmark. And then some would divide it further into patients who have more or less proteinuria. And in proteinuric patients, they might target a stricter blood pressure, let's say less than 130 millimeter mercury. And the reason that the meta-analysis may not be a game changer in this respect is because the average blood pressure level achieved in the quote-unquote stricter blood pressure control arm of all these 18 clinical trials was 132 millimeter mercuries. So that would sound like a reasonable and a pretty commonly targeted systolic blood pressure target in patients with chronic kidney disease with or without proteinuria. It certainly wouldn't elicit the kind of feelings that one might see if we wanted to target, for example, something even stricter, like less than 120 millimeter mercury.
Okay. Well, so the meta-analysis found a roughly 15% lower relative risk for all-cause mortality with more intensive pressure lowering. And so the difference between the mean pressures in the aggressively treated group and the non-aggressively treated group was 8 millimeters of mercury, as we were saying. That's a relative risk. And when you look at the illustration in your editorial, you see that the difference in the advantage in mortality rate is vanishingly small in that range, in that 8 millimeter of mercury range. It's a less impressive result when you're trying to go from 140 to 132. Would you agree?
Yes, and this was one of the points I was making in the editorial towards the end, that even if we accept that lowering blood pressure to that level is beneficial, since we have this J-curve phenomenon, which we could discuss later, the benefits accrued are diminishing as we achieve better and better blood pressure control. Clearly, the patients who are at the highest risk of cardiovascular complications or mortality complications from high blood pressure are the ones who have very high blood pressures, and in them clearly treating blood pressure and lowering it to even a more acceptable level, which may still not be ideal, has huge benefits. And one way we can quantify this is the so-called number needed to treat, which is basically the inverse of the absolute risk reduction. And I made a point there that one of the first clinical trials was, by the way, a VA cooperative trial done in the 60s that showed that if you treat virgin, untreated patients whose starting blood pressure is extremely high, more than 180 over 120, you have an immense treatment benefit. I mean, this was a very small clinical trial by today's standards. It wasn't, a couple of hundred patients, and treatment versus placebo, because back then you could do placebo. We didn't even know that treatment is beneficial. Had such a large effect that, especially on stroke, that you could achieve statistical significance with even a very small number of patients. And the number needed to treat to prevent even one adverse event was less than 3 patients. So by treating even 2.8 patients, I think you could prevent 1 stroke or 1 death. Comparatively, if you get down to these stricter blood pressure controls and you're lowering blood pressure from 140 to 130, for example, if we accept the risk reduction reported on average in this meta-analysis, then we're talking about hundreds of patients that would need to be treated. So for this particular case, the number needed to treat would be 167 to prevent 1 all-cause death.
Yeah. So you mentioned, getting from 140 down to 132. In other words, that difference. Or, I mean, if you're starting at 150 and you get going from down to 140 versus going down to 132, or more aggressively down to, say, 120. You say in your editorial that there were trade-offs involved. On the one hand, there's that lowering of all-cause mortality. So that's a benefit. But on the other hand, you mentioned the adverse effects of too aggressive treatments. So can you give an example or two of what are some of the adverse effects of too aggressive treatment among people who may not need to go under 120?
Right. So everybody would agree that a low blood pressure, there is such a thing as a blood pressure that's too low. Right. Nobody wants to treat a patient to a systolic blood pressure of 70 millimeter mercury. Okay. That may become symptomatic. And to the extent that a certain individual has a lesser tolerance, for example, for blood pressure reduction, you could envision that quote-unquote aggressive blood pressure lowering might cause, for example, symptomatic hypotension, dizziness, low energy, interfere with daily life, cause orthostatic blood pressure drops, and in an elderly population, for example, it could lead to falls, which can really have deleterious consequences. The debate here is really where that sweet spot is, and that's why the title of the editorial, because most people believe that there is a J-curve. We just can't agree on where the sweet spot is. How low can we go with the blood pressure to push towards improved outcomes without having these adverse consequences. And I have to tell you that one pleasant surprise was the SPRINT trial, which was just recently published and which motivated many of these secondary analyses, including this meta-analysis. As you know, the SPRINT was a very large clinical trial of strict blood pressure control versus usual blood pressure control in patients at high cardiovascular risk who did not have diabetes. So it was a non-diabetic study, patients who did not have prior stroke. And interestingly, and that's why this is very interesting for nephrologists, is that SPRINT included patients with chronic kidney disease. About 1/3 of the participants had chronic kidney disease, and mostly CKD stage 3A, meaning that they had the least severe form of chronic kidney disease, but they could include patients with estimated GFR more than 20 and less than 60. So in SPRINT, regarding the symptomatic nature of blood pressure lowering in the stricter arm, it was surprisingly well tolerated, even in the more elderly patients. So there were subgroup analyses with patients more than 75 years old. And even in those patients, the composite outcome was significantly favoring the strict blood pressure control arm. So in that sense, there's clearly at least a certain phenotype of the population that tolerates these stricter blood pressure lowering interventions.
But with the sprint data comprised about, I don't know, 10% of the population used in the meta-analysis. I think the sprint data.
The CKD part, yeah. So sprint was around 9,000 patients, and about a third was CKD.
Yeah, and so the way that they measured blood pressure in sprints is controversial. And you mentioned in your editorial that if they had used that in the other trials, if they had used the same method in the other trials, then the results might be different on this meta-analysis. Am I misreading what you said?
No, in effect, I think there is a sense that sprint had a large impact on our thinking, maybe that strict blood pressure control may be beneficial, and also on the results of the meta-analysis, in the sense that it showed a striking benefit on all-cause mortality, for example, from strict control, which was defined as a systolic blood pressure of less than 120 versus 120 to 140 in the usual control arm. Now, Sprint used this research method. It was basically an automated blood pressure monitor method where it was protocolized. It was implemented according to pre-specified criteria. Oftentimes, the patient was left alone in the room, and with the operator, the research coordinator, for example, leaving the room, and the machine checking the blood pressure several times and then averaging it. And there is a sizable literature on this topic indicating that when you compare this type of blood pressure measurement with the typical clinic measurement, then the typical clinic measurement is considerably higher, the blood pressure, up to 10 to 15 millimeter mercury systolic higher. And since most of the clinicians use these typical blood pressure measurements, and they don't have the resources or the time to engage in these very meticulous and sophisticated measurements of blood pressure, it is conceivable that what Sprint defined as a strict blood pressure that is less than 120 would in fact be more like less than 130, and their achieved blood pressure was right around 120 plus. So it would put us exactly in the sweet spot that's shown in this meta-analysis. And the question I raise is, if you take Sprint out, would the result change? And actually the authors did perform a sensitivity analysis where they removed Sprint, and the results did not change. The question in my mind, though, was if you reallocate Sprint. So rather than take it out altogether, you say, okay, so you reallocate the blood pressures in Sprint to different groups within the meta-analysis. So instead of less than 120, you put them into the 130 group for this control. Would that affect the subgroup analysis, which indicated that even in studies that used a blood pressure less than 120, the benefit was similar to the other groups?
Well, it's really a balancing act, isn't it? And what would you have as a result of Sprint and of this meta-analysis and of your thinking about the J curve, what would you have your colleagues do differently, say, next week than they were doing last week when it comes to trying to lower blood pressure in chronic kidney disease?
Well, to some degree, Sprint gives us comfort that it's okay in certain patients to push the pedal harder and attempt stricter blood pressure control if the patient tolerates it. And we do that to an extent that it proves that it's not necessarily deleterious to lower blood pressure to a lower level. Having said that, Sprint was really essential because the bane of nephrology is that there is a dearth of large randomized controlled clinical trials. So a lot of our knowledge is based on extrapolations, based on pathophysiologic thinking, and trying to find the best solution based on imperfect evidence in our day-to-day clinical practice for a certain individual. And to that extent, I think Sprint was a leap forward. What I would caution is to go overboard in our conclusions and conclude that after Sprint, we know everything about blood pressure treatment in CKD, and every patient with CKD can now be treated like Sprint. Uh-huh. And what gives me pause primarily is that when determining CKD and in their analysis, Sprint used a dichotomized definition in that they had patients with or without CKD defined as an eGFR more or less than 60 mLs per minute. And in that type of statistical analysis, they did not find an interaction for the effect, claiming that the effect in CKD is similar to the overall population or in the non-CKD population, in spite of the confidence intervals being wider and the point and not being statistically significant. So when you look strictly at the CKD population, the benefit was not statistically significant, although it was nominally lower, i.e. better. Yeah. So the problem with that approach is that by dichotomizing the CKD group, you think that you apply this knowledge to everybody with CKD, but as we know, CKD is a continuum. And when you look at the composition of Sprint, the CKD group was mostly composed of patients with the mildest form of CKD, that is, estimated GFR between 45 and 60. And there are some ongoing secondary analysis of Sprint. There was the Sprint Challenge, which NEJM also championed, of course. Yeah. And in Sprint Challenge, I cannot really talk about it much because these are papers that are not published yet. Okay. But there are analyses that assess CKD differently. In that when you look at it as a continuous variable, you might see different results in the sense that they're not uniform when you look across the continuum of estimated GFR. And if we find that the mortality benefit vanishes, for example, or diminishes with more advanced stages, we may be able to make our assessment more granular and maybe a little more sophisticated when we approach our patients.
Okay, so I guess what you're doing is you're waiting for more results before you set a new course on the clinical map.
Well, look, one interesting thing is that in the wake of Sprint, we will see reevaluations and reformulations of guidelines. Okay. And in fact, there was just a KDIGO controversies conference on blood pressure control in CKD just this past weekend in Scotland, and much of the discussion revolved around the effect of Sprint on our thinking and how we should approach blood pressure therapy. Uh-huh. These controversies conferences are usually followed by a guideline conference and the establishment of updated guidelines, which we should expect sometime in the next year. And, we'll see, because these assessments then take into consideration everything that was accumulated since the last guidelines, including Sprint and including the controversies that surround it. Whether or not there will be a recommendation to change the blood pressure goals from the current less than 140 to something stricter remains to be seen. Uh-huh. I think Sprint was extremely useful in giving us guidance, and hopefully it will prove to be a launching pad towards more studies.
Would you predict that it would be closer to 130 than 120 in the new guidelines?
Well, it's really difficult to tell, because the data is not as clear, and there's a lot of question marks. For example, Sprint enrolled only non-diabetic patients and patients without previous stroke. And if you consider that blood pressure lowering to these stricter levels is so beneficial, then why wasn't a similar benefit found, for example, in diabetic blood pressure lowering trials such as ACCORD, even though they did not have a CKD group? Yeah. But the success of Sprint was not replicated by diabetic studies and in patients who are at even higher cardiovascular risk. And it just raises a lot of questions which make it very difficult to be overly exaggerating and generalizing about how we should treat stricter blood pressures. I wouldn't be surprised to see something that approves of maybe stricter blood pressure control, but cautions and maybe also advises individualized approaches to patients.
So that was a tough question, and I didn't mean to put you on the spot, but we'll see. We'll see what the new guidelines say in about a year's time. I want to thank you very much, Dr. Kovesdy, for spending time with us today.
It was my pleasure, Joe. Thank you very much for the opportunity.
That was our 212th edition. All earlier conversations may be found at podcasts.jwatch.org. We come to you from NEJM Journal Watch. Kristen Kelly is the executive producer here for the NEJM Group. I'm Joe Elia. Thank you for listening.